At Mid-America Heart Institute, we do about 4,000 to 5,000 PET perfusion tests every year. And hopefully in the next 10 to 12 minutes, I will convince you why I believe stress PET is the non-invasive gold standard for functional assessment of chronic coronary artery disease. Traditionally, our diagnosis as well as management efforts in chronic ischemic heart disease have focused on identifying and treating obstructive epicardial coronary artery disease. While that is important and is a common cause, our understanding of the risk spectrum of ischemic heart disease has evolved over the past few years and now includes patients with coronary microvascular dysfunction. These are typically patients with multiple comorbidities such as diabetes, hypertension, which affects the microcirculation. It also includes patients with diffuse non-obstructive coronary atherosclerosis as well as coronary vasospasm. These phenotypes are present in as much as 70% of patients with chronic ischemic heart disease and are associated with a higher cardiovascular risk. And stress PET can identify and differentiate between most of these phenotypes across the risk spectrum for chronic ischemic heart disease. These are the commonly used PET radiotracers, which Dr. Mahapatra mentioned. We use rubidium and ammonia in the United States. Flurpiridaz, F18 flurpiridaz is currently under phase 3 clinical trials, and once approved, it has the potential to really change this field as it will enable us to procure unit doses from a regional cyclotron instead of investing in expensive generators or on-site cyclotrons. Given the short half-lives of these PET radiotracers, we typically combine them with pharmacological stress agents. However, treadmill exercise is possible with ammonia and flurpiridaz. However, it won't give us quantification of myocardial flow. The short half-life of these radiotracers is important because it leads to a really low radiation dose to the patient. Typical radiation doses with rubidium and ammonia PET are much less than 4 millisieverts compared to more than 10 to 15 with a traditional technetium or thallium SPECT study. The tracer characteristics also enable us to image the patients at peak stress and allow us to calculate peak stress LV function and quantify absolute blood flow at peak stress. These characteristics help us identify more disease and increase the sensitivity of PET to detect coronary artery disease. And lastly, these PET tracers have an excellent first pass myocardial extraction. What does it mean? It means that more radiotracer is uptaken by the myocardium proportional to the blood flow. And that helps us to detect even milder perfusion defects and gives us better defect resolution. It improves the myocardial counts, radiotracer counts, and also allows for more precise quantification of blood flow. All these characteristics make it less likely to have a false negative test with a PET and contribute to the high sensitivity of a stress PET test. This is a typical rest stress PET protocol. We start with a CT topogram and a low-dose transmission map, which we use for attenuation correction, but this can also be used to look for coronary artery calcification and identify subclinical disease, followed by radiotracer injection and image acquisition, rest and stress. The entire rest test protocol takes about 20 to 30 minutes max to complete. So this allows for much better efficiency and throughput of testing as well. So what information is available from a stress PET study? First, we get these relative perfusion images similar to what you get with SPECT as well, where you can quantify the extent and severity of a reversible perfusion defect, which we call as ischemia. We can also look for scar with fixed perfusion defect. We can compare volumes at stress and rest and look for transient ischemic dilation. Now you'll notice that this perfusion image is crisper and is of much better image quality than what you may be used to seeing with a SPECT study. And why is that? There are a few different things. First, all of these images are attenuation corrected with either line source or CT attenuation correction based on the camera or scanner that's being used. All PET images are also scatter corrected. The scanner characteristics also enable us, the PET, to have a much higher spatial resolution in the range of 4 to 6 millimeters compared to SPECT, which is between 10 to 15. And because of the high energy of the radio tracer and the scanner, there's less interference of radio tracer uptake from gut and other organs. All of this leads to much higher specificity, a very low false positive test with PET, which contributes to the high specificity. In addition to perfusion, we can also measure LV and RV systolic function with PET, not only at rest, but at peak stress, compared to pharmacological SPECT, where we often have to wait 30 minutes to an hour with technetium label agents to obtain our stress images. This allows us to look at a drop in ejection fraction at peak stress, which is a marker of ischemia, and also look for transient stress wall motion abnormalities. In fact, this drop in EF with peak stress on PET, which is a mark where we use a marker called LVEF reserve, a negative LVEF reserve, actually has been shown to closely correlate with high risk multivessel disease. And it's also been shown to be a high-risk marker and predicts adverse cardiovascular events in addition to just perfusion imaging. But perhaps the most important benefit of a PET, a stress PET, is its ability to quantitate myocardial blood flow. Typically, the invasively measured FFR helps us identify the hemodynamic significance of a focal epicardial stenotic lesion by looking at the pressure difference across it. It can be affected by disease within the microcirculation downstream. What a non-invasively measured myocardial flow reserve or coronary flow reserve, which can be invasively measured, does, it looks at the hemodynamic significance across the entire coronary circulation, including epicardial stenosis and diffuse disease and or microvascular disease on myocardial perfusion. So let's see, how does myocardial blood flow quantification help us? Let's take an example of this 70-year-old female with comorbidities who presents with symptoms and has this perfusion image. We can all agree that it looks normal, right? But whether if it's truly normal or whether this is from balanced ischemia from multivessel disease, or whether the patient is having symptoms because of diffuse disease or microvascular dysfunction, is something that cannot be determined just looking at these perfusion images. And this is where myocardial flow quantification can help us in differentiating these different phenotypes. So if that patient has this flow map, so these are the rest flows, these are the stress flows, and this is the flow reserve, which is a ratio of stress flow to rest flow within each territory, each pixel basically, as well as overall. So you can see that in this patient, she had very good augmentation of blood flow at stress and had a flow reserve much greater than 2, which is considered normal. This tells us that she had a very good vasodilator response and that this is truly a low-risk normal study. In contrast, if we see something like this, a regional decrease in stress myocardial flow and a regional decrease in flow reserve, even when the global flow reserve is normal, if the patient has normal perfusion, this helps us uncover single vessel disease. And if the patient has a perfusion defect in this territory, it helps us confirm that this is indeed single vessel involvement and that the other territories do not have significant obstructive disease or diffuse disease or microvascular disease. Let's take this example. Here, the stress flows are diffusely reduced in all 3 territories. And I don't have the numbers here, but there was no gradient from base to apex. This pattern is commonly seen in diffuse atherosclerotic disease with or without microvascular dysfunction, which can be treated medically. And in the end, really severe reductions in global in stress flows across all 3 territories with or without presence of a perfusion defect can help us identify multivessel involvement. This patient had significant 3-vessel disease, which cannot be just determined just looking at perfusion alone. Multiple retrospective studies have shown that PET has higher sensitivity and specificity compared to PET. However, recently we have a prospective study of 208 patients where all patients got a PET, SPECT, and a coronary CTA, and this was compared with cath FFR as the gold standard. And PET was shown to have the highest diagnostic accuracy of 85% compared to SPECT and coronary CTA. PET also helps in improving risk stratification of patients with coronary artery disease. There's been multiple studies. This is a recent study from our group where we showed that even in patients with no ischemia or mild ischemia, patients who have low myocardial flow reserve on PET, they had much higher risk of cardiovascular events and death compared to those with normal flow reserve. Not only that, PET can also help us identify potential candidates for select candidates for revascularization. In this study from our center, in more than 16,000 patients, we saw that patients with greater amounts of ischemia on PET had a higher long-term survival if they underwent revascularization. Notably, the threshold for the ischemic threshold seen here was much lower. It was between 5 to 10% compared to 12 to 15%, which has previously been shown with SPECT. And not only that, we extended these observations to see how flow helps us. So we noted that patients who have a reduced flow reserve, in addition, the cutoff was less than or equal to 1.8 in our cohort of rubidium PET. So patients with less than myocardial flow reserve less than 1.8 actually had a higher long-term survival if they underwent revascularization compared to medical therapy. And we can combine these two studies and note that only patients, even if you have ischemia or a perfusion defect, only the patients who have a reduced flow reserve actually are the ones who are having survival benefit with revascularization. And those who have a normal flow reserve, despite the presence of ischemia, do not have a survival benefit with revascularization. So hopefully I have shown you that PET is a very powerful test across the entire risk spectrum of chronic ischemic heart disease. It's especially important in patients with intermediate to high risk, high pretest risk, such as those who have multiple comorbidities which make them more likely to have microvascular disease, and patients with known coronary artery disease. It can help us diagnose obstructive epicardial disease, but also other phenotypes such as diffuse atherosclerotic disease and microvascular disease. There are multiple risk markers on PET in addition to just perfusion, which help us further risk stratify these patients with chronic ischemic heart disease. Not only that, PET does have a potential role in selecting patients who should undergo revascularization.